a growing health problem. If we look at data of heart failure with reduced ejection fraction, despite the availability of several therapies, established efficacy in heart failure with reduced ejection fraction, mortality rate remains unacceptably high. 5-year mortality rates are nearly 75% with HFrEF. The proportion of patients receiving guideline-directed therapy is also very less. Like in data, beta blocker was given to heart failure with reduced ejection fraction in only 22% patients. ACE inhibitor to 22 and beta blocker to 12% only. These are trial data. Real world data is even lesser than this. FPF, unfortunately, there are no treatment option well defined till now. For FPF, all guidelines says treatment is based on treatment of comorbidity and treatment of symptoms.
20 to 12% trial data. रियल वर्ल्ड
रियल वर्ल्ड जैसे पण आपली
रियल वर्ल्ड ट्रायल માં તો બધાને આપી એટલીસ્ટ 50-50 તો હોય જ રેન્ડમાઇઝ
not up to the recommended dose. Like like we are talking about metoprolol dose is near
but it has to be real world.
Yes,
the shadow statement is real world dose so the reference.
Then cardiorenal syndrome, again treatment criteria and treatment parameters are not defined properly. The main treatment remains treatment of cause. Stable heart failure, does it exist, does it a problem? So in clinical trial with median follow-up of 3 years, 34% of stable heart patients who are in NYHA class 1 and 2 had mortality. So stable heart failure is again a problem, and the problem does exist. While versus compared to unstable heart failure, that is class 3 and class 4, 42% mortality has been noted. This 34% patients can be saved. If
so our data can be shared.
આ ડેટા હું ભૂલી ગઈ હું મોકલું તમને આ છે ડેટા મારી પાસે આખો આર્ટિકલ છે
અને આ બધા જે 34 અને 42%
older. This is 2020 2019.
okay, still it is not that old, but if this is an this much is only difference, then the cause of death must be much more than cardiac issues.
Yes.
કારણ કે 34% તો તમારા ક્લાસ 1 ક્લાસ 2 વાળા જો મરી જતા હોય અને ક્લાસ 3 ક્લાસ 4 વાળા 42 જ મરતા હોય તો એ 34 માં નોન કાર્ડિયક ડેથ બહુ બધા છે.
Yes, but because this 42 are much more treated as compared to 34%.
So સ્ટેબલ એમાં એને સ્ટેબલમાં શું ઇન્ક્લુડ કર્યું છે એ આપણે જોવું પડે કે આપણા માટે સ્ટેબલ અલગ હોય છે એના માટે સ્ટેબલ અલગ હોય છે.
They are included class 2 versus class 3 class 4.
34% of cause of death may not be only failure.
This is total mortality.
So it is a stable heart failure and our real world data છે કે ટ્રાયલ ના છે. This has to be trial. Real world માં તો ક્લાસ 1 ક્લાસ 2 તો ખબર જ
નથી. In the sense, this is a limited data, limited to some 10-12 centers.
Exactly. એટલે પણ આ બહુ ઇન્ટરેસ્ટિંગ વસ્તુ છે. આ પેપર હોય તો જરા મોકલજો.
Okay.
All cause mortality.
Yes. Then evaluation of treatment of heart failure with reduced ejection fraction. So in 1980s, the treatment started with introduction of ACE inhibitors and ARNIs, followed by 1990s beta blockers were introduced, followed by mineralocorticoid receptor inhibitors. There are multiple trials. These are all proven therapy, and these are the pillars of heart failure till 2000. 2000 device therapy started taking up, that is ICD and CRTs. In 2010, the new drug came in market, that is sacubitril valsartan, that is ARNI, that is what our topic is about. And paradigm HF trial changed the guidelines, and the ARNI suddenly became class 1 indication. In 2020, new drug has been introduced, that is SGLT2 inhibitors and very secure. So what is the rationale of giving neprilysin inhibitor along with angiotensin receptor inhibitor? So one of the substrate of neprilysin is angiotensin 2. So when we give neprilysin inhibitor, angiotensin 2 concentration will increase. So to counteract this action, neprilysin is given along with either ACE inhibitors or angiotensin receptor inhibitors. That is a RAS blocker basically. So that inhibits entire RAS axis. Omnapatrelate was tested neprilysin plus ACE inhibitor, that was first, but it was later on discontinued because it had multiple episodes source of angioedema that are secondary to ACE inhibitor versus ARB. ARB does not have so much of angioedema. That's why the combination of neprilysin with angiotensin receptor inhibitor started. As of now, we have only one combination, neprilysin with valsartan. Fortunately, market, there are news are there that neprilysin with telmisartan is also in the pipeline, and that will also come in upcoming years. Paradigm HF, that was 2014. That gave us the new evidence for heart failure treatment with ARNI after a decade. In Paradigm HF, study patients were followed up for 27 months. In these patients, it was observed that 26.5% of all patients randomized to enalapril experienced cardiovascular death or heart failure hospitalization as a first event. And out of this, 41% patients experienced cardiovascular death as a first line event. Of all patients randomized to enalapril, the absolute risk of cardiovascular death was 10.9%. So these are very high death. 26.5% patient experiencing cardiac problem, 10% mortality, 41% having first event as a CV death. These are very high mortality. As compared to this, enalapril, neprilysin inhibitor or ARNI has significant less number of death at first year. That is 15% death are reduced by ARNI. ARNI kept HFrEF patient out of hospital also. It's not like that it only reduces mortality. Reduces morbidity also. The primary composite outcome, that is composite of CV death as well as heart failure hospitalization, reduced by 20%. CV death alone reduced by 20% with ARNI, and heart failure hospitalization also reduced by 21% by ARNI. If we go ahead, 2016 ESC guideline, the ARNI was added as a class 1 indication for heart failure therapy with reduced ejection fraction that time. American guidelines 2016, ARNI was added as a class 1B. They added one subclass R, that is class 1B randomized, as a class 1 indication for heart failure with reduced ejection fraction. So now we all know that there are multiple trials beyond this. ARNI is class 1 indication for heart failure with reduced ejection fraction. What about ARNI in acute decompensated heart failure? So that answer was given by Pioneer HF trial in 2019. That trial included nearly 881 patients who are having heart failure with ejection fraction of less than 40%. Again, this is a trial with reduced ejection fraction. And who has high BNP more than 400, that is acute decompensated heart failure. So when this patient was started early on ARNI, there is quick reduction in LV wall stress. That is ascertained by change in anti-proBNP level. Anti-proBNP level started reducing after first week of initiation of therapy. So earlier the better. If we look at the data, how this has been extrapolated into the clinical practice, the death, heart failure rehospitalization, LVAD use, transplant listing has significantly reduced with use of sacubitril valsartan as compared to enalapril when they are started early in acute decompensated heart failure. Heart failure rehospitalization beyond 1 year up to 4.5 years or 5 years has been significantly reduced. Up to 2 months, that has significantly reduced. And even yearly data which is going to be published for this trial has also shown reduced heart failure rehospitalization even beyond 2 years. So, to conclude this segment, Pioneer HF study decreased anti-proBNP level by 30%, and the benefit started showing from first week after initiation of therapy. Mortality reduced by 34%. Benefit started showing from first week and it continues yearly.
What will happen to BNP levels?
It will reduce.
BNP will increase.
Initially BNP will increase because again natriuretic peptide.
BNP will always be increased in patient on ARNI because ARNI
neprilysin is
so that is why
natriuretic peptide is a substrate for neprilysin. So it should
exactly. So
increase.
what is the difference between BNP and anti-proBNP?
That I
Oh dear. So BNP is basically active ઘટક છે ખાલી it generally goes excreted by
So
kidneys.
the BNP is
So-
bound to increase initially, but once
No, even on if your patient is on HFrEF patient on ARNI and HFrEF patient not on ARNI, if you check BNP will always be more in ARNI patient. So that you need to always realize. So if you are checking this patient with BNP on ARNI, it will be falsely elevated. This you need to keep in mind. You have to check NT-proBNP only.
Okay.
So then how will we know the response to drug therapy?
Anti-probian, always.
Generally, મોટે ભાગે there has to be clinical because of two reasons. આ patient ને underlying kidney disease હોય જ છે. બરોબર છે? Whether creatinine is normal or abnormal, whether USCR is normal or abnormal, these two are still gross marker of kidney function. If your patient is having acute decompensated heart failure, it is rather unusual કે એની kidney સાવ normal હોય. ઓકે, એટલે એ પેશન્ટમાં ફોલ્સલી એલિવેટેડ બંને વસ્તુ આવવાના ચાન્સ વધારે છે, પણ આ પેશન્ટ ફોલોઅપ પર આવે then you have to check NT-proBNP. You will never check BNP. BNP will be falsely elevated because of neprilysin inhibitor.
Always anti-proBNP. And in our country, anemia is also contributing to certain extent. So we are also getting like what the kidney is contributing, same way anemia in our country is also very common. Which is also
So form કઈ રીતે થાય, you know that what is anti-proBNP BNP ક્યાંથી આવે?
And BNP will get released from the atrium. That is a
So as and when your cardiac myocytes are stretched,
Yes.
pro-BNP is produced first. Pro-BNP is then in active form BNP and anti-proBNP which is inactive form.
Inactive.
Okay. Neprilysin क्या है?
Neprilysin is in kidney as well as liver. Both.
Kidney, gut, placenta, many other endothelium.
Yeah. And, but not in heart at least.
ના હાર્ટ માં
Not in heart.
હાર્ટ ને તો જોઈએ છે વધારે એના માટે ડિફેન્સ મિકેનિઝમ.
Yes. So as compared to enalapril, Pioneer HF did showed an edge with ARNI over and above in transition study also. That is a relatively recent study 2020. It also showed 11% reduced incidence of time to first heart failure readmission and 11% decreased incidence of time to first cardiovascular death also.
સોરી ઇન્ટરપ્ટ અગેન કરું છું પણ સ્ટુડન્ટ્સ માટે that why is anti-proBNP a better lab marker than BNP apart from one that we have
More
discussed?
sensitive.
Why?
BNP gets increased in multiple other situations also, even in renal patients.
So BNP will never increase without anti-proBNP. It is not possible. એવું છે જ નહીં. તો તમારો એક પોઈન્ટ ખોટો છે. Why it is more checked in lab anti-proBNP? Because it is more stable. The half-life is longer. BNP half-life is much shorter. તો તમારું જો ઇમિડિયેટ તમારી લેબમાં ચેક ના થાય અમુક કવર પછી થાય તો તમારું ફોલ્સલી લો આવે. એન્ટી-પ્રોબીએનપી એને કોઈ પ્રિઝર્વેટરની જરૂર નથી, પ્લેનમાં લઈ અને તમે મોકલી દેશો તો બી એ 2 થી 3 દિવસ.
Guidelines are now on anti-proBNP.
Exactly. So anti-proBNP is a better marker for lab, not BNP. Right? This is always used. The student માટે છે.
પણ criteria એમાં પણ છે કે it has to be measured within 6 hours after collection of blood. નહીતર તો એમાં પણ ડિસ્ટર્બન્સીસ આવે છે.
આ તો રિમોટ પ્લેસ પર હોય તમારું બ્લડ બીજે ક્યાંય જવાનું હોય તો એન્ટી-પ્રોબીએનપી યુ કેન સ્ટીલ અપ ટુ 2 to 3 days it is stable.
2 to 3 days
2 to 72 hours.
ખબર નથી હા, પણ મને એવું ખ્યાલ છે કે ત્યાં સુધી તમારે 6 કલાકની અંદર એનું કલેક્શન થયા પછી
આ બધું વાંચેલું છે એક જમાનામાં, હવે ચેક થઈ ગયું તો ખબર નથી, પણ એન્ટી-પ્રોબીએનપી 2-3 દિવસ લગી તમે ચેક કરી શકો સેમ સેમ્પલ.
So then comes true HF study again for HFrEF only. It showed 9.4% increase in LV ejection fraction with sacubitril valsartan. LV end diastolic volume index reduced by 14%. So there is definitely decreased stress on the heart. LV end systolic volume also decreased by 25%. LA volume index also reduced by 20%. And there is 11% decrease in diastolic dysfunction rate with ARNI. So that again led to change in guideline in 2017-18. 2017, ACC told us that there is a direct to ARNI approach is now recommended. Initially, before 2017, the guideline was to start with ACE inhibitors or ARBs. After 3 weeks, change to ARNI. But now it is direct to ARNI without any ACE inhibitors, ARBs is the approach on all the guidelines. What about ARNI beyond heart failure with reduced ejection fraction? So There comes another trial, that is a Paramount HF. In HFpEF patient, sacubitril valsartan as compared to valsartan alone showed decrease in antiproBNP at 12 weeks. In left atrial volume, decrease at 36 weeks. So here also cardiac remodeling is going up. Even in heart failure with preserved ejection fraction. Paragon HF trial for HFpEF patient, decrease in risk of heart failure hospitalization and CV death, decrease in risk of heart failure hospitalization alone, decrease in risk of cardiovascular death alone also, and decrease in all-cause mortality with ARNI.
But the p values were not significant.
P values are not significant. That's why guideline did not change. Guideline still says for HFpEF patient or heart failure with mid-range ejection fraction now, that is a newer subset. Diuretic is class 1 indication. SGLT2 inhibitor is class 1 indication. ARNI still remains class 2B. MRI remains class 2B. Beta blocker remains class 2B. For HFpEF patient, same. Diuretic class 1, SGLT2 inhibitor class 1. Treatment of comorbidities and etiology is class 1. ARNI, there is no mention as of now in guidelines. Because the data is not very robust, like we have data in HFpEF patient. What are other effects of ARNI? As we have seen, ARNI reduces myocardial stress. ARNI also reduces inflammation also, which is a marker for coronary artery disease also as well as heart failure also. ARNI decreases neurohormonal activation because it acts on a RAS system. It decreases fibrosis also. Beyond heart, it has multiple other effects. In paradigm HF and Paragon HF, it has been shown that
So are those effects are direct effect of ARNI or indirect effects of ARNI?
indirect effect.
Has to be indirect, right?
Yes.
Hemodynamic effect જે આવે એને લીધે જે changes આવે છે.
That is because of diuretic.
It's very clear.
Yes, so that is also one counter argument why it has been reduced. So we don't know, but
We don't.
even if it helps by 1% to 1% patient,
See, ના એવું નથી તો આ તો કેવું છે ટ્રાયલ આ યુનિડાયરેક્શનલ હોય આમ જ જોવાનું બરોબર છે કારણ કે આ પેશન્ટનો તમે એનિમિયા જોશો આનું ફ્લુઇડ ઓવરલોડ જોશો તો HbA1c લેવલ પહેલા જે તમે ટ્રાયલમાં ઇન્વોલ્વ કર્યા હોય ત્યારે પછી પેશન્ટ સ્ટેબિલાઇઝ થયા હશે તો HbA1c આમ થાય પ્લસ માઇનસ થવાના
yes, yes.
હવે ખાલી HbA1c ઉપર ડિસિઝન ના લેવાય પણ ઠીક છે ટ્રાયલ આ લોકો ડેટા પર જ બોલતા હોય એટલે ચાલે બાકી ક્લિનિકલી આવું ઇમ્પ્લાય કરવા જાવ ને તો હેરાન થઈ જાય.
And trial does include cardiac rehabilitation also. Maybe that is also reduced HbA1c. So we don't know. This is a hypothesis and observation.
You will accept the stress recurtation.
Yes. This is observation. Then one more observation is ARNI in uric acid. To a certain extent, this is observed frequently. So in paradigm HF, Paragon HF trial, reduction in uric acid, reduction in gout, and reduction is need to introduce uric acid lowering medicines were found to be patient receiving sacubitril valsartan. This has also been observed. Although we do not have p-value, we do not have comparison, we do not have data.
So આવા ઓબ્ઝર્વ ડેટા ફિઝિશિયનના દિમાગમાં કેમિકલ ઓછા કરવા મૂકવામાં આવે એટલે ઘણા લોકો લખવા માટે સિમ્પલ બરાબર સાહેબ
બિલકુલ સાચી વાત. 0.5 નો ડિફરન્સ આવ્યો હોય ને તોય.
And there is one more data for ARNI and anemia also.
It improves. Anemia भी improves.
Hemoglobin reduction with sacubitril valsartan has been observed less as compared to ACE inhibitors.
यार આ બધાને
આ
ચેક
કઈ
કરી
રીતે
અંદર.
માનવું? મતલબ તમે ફ્લુઇડ ને તો સાવ ઓલું જ કરી નાખ્યું હે ને
Same. Hypothesis is that substance.
એટલે ઓબ્વિયસલી તમે વોલ્યુમ ઓછું કરો એટલે કોન્સન્ટ્રેટેડ થઈ જવાનું.
હજી વધારે ડાયલ્યુટ કરું what was the number of patient at the trial initiation and what was the number of patient at 36 weeks
This is no head-to-head comparison. This is
ના પણ
observation.
ના મેરાથોન HF નો જે ટ્રાયલ છે એમાં એનરોલ કેટલા પેશન્ટ કર્યા હતા અને 36 માં વીક પર કે 36 માં મંથ પર કેટલા
The
પેશન્ટ
Paragon HF has very low attrition data.
So
Less
that-
than 10%.
આ બધું જવાબ.
ના હશે
Less than 10%.
ના ના વધારે જ હોય તો
નહીં.
લેસ ધેન 10% તો એકે ટ્રાયલમાં એટલો ઓછો ના હોય
They claimed it.
જે ડાટા છે
Paragon and Paradigm.
તું ખોલ ડેટા અત્યારે ખોલ લેસ ધેન 10% એટલે ડિગ્રી આપી દઉં દોસ્તો મારી શક્ય જ નથી લેસ ધેન 10% એટ્રિશન રેટ 36 મંથ્સ છે કે વીક્સ છે
36 months.
Once 36 month मतलब 5000 કેટા તો ખાલી 500 થી ઓછા કોલ આઉટ થાય
Yes.
અરે it is not possible 110% જોઈ લેજો
Okay.
આપણે રેગ્યુલર ડિસ્કસ કરવા.
So it has been observed.
જોઈએ આપણે હમણાં કરી જ જોઈએ
Then this is other ACE inhibitor alone or valsartan alone. So for patients with CKD also, ARNI is beneficial. Although it is sometimes it increases creatinine. What about safety profile? There is an increased risk of symptomatic hypotension, but there is a lower risk of worsening renal failure. Although it is contradictory, guidelines is continued.
Oh, clearly.
Because why I stop? Because our patients are not in follow-up regular. They will come to you for after 15 days with creatinine. If it is increased, if you will not stop ARNI, they will come after a year or 2 years with sudden create of 4 and 5.
So guideline is like a stable 30% should be charged.
Yes,
30%
up to stable 30% it is allowed. Beyond 30% reduce the dose, beyond 50% stop. Rather than creatinine, you look at this GFR level. Below 30 also, GFR less than above 60 it has to be given. 30 to 60 it has to be given. Below 30, again, if patient is having stable GFR of less than 30, it can be given.
Never.
Yes, it can. Less than 25 it is not given. That is a new change. 25 less than 25. No, not trials. These are newer, not even in guidelines. These are some recent some observational articles.
Guideline
Not in
observational
guidelines. Trial. And these are now 4 pillars: RAS inhibitor or ARNI to be started first as early as possible, even in patients with acute decompensated heart failure also. But there are criteria when to start it. Once patient is off diuretics or one patient is on stable dose of diuretic, one patient is off inotropes, one patient is off O2 support, then only we should start ARNI in acute decompensated heart failure also. Followed by beta blocker, followed by MRI, followed by SGLT2 inhibitors. And step up everything to maximum possible level.
So the point is that before discharge, you try to put all patient on 4 drugs.
GMT is to an high exercise class.
Yes, all 4. Even if minimal possible dose. Now for ARNI, minimal possible dose is 50 milligram twice a day. But for Indian patients, we are using 25 milligram twice a day also. And that is also showing effect.
बहुत सारी इफेक्ट આવે છે
અને બહુ સારી આપે છે આપણે 200 ની કે 100 ની ક્યારે ઉપયોગ જ નથી કરવાનો
200 આપણે પૂછતા જ નથી કરી બસ
બહુ ઓછામાં આર્ટિફિશિયલ
પેશન્ટમાં જ મારે
મેં 7-8 પેશન્ટમાં 200 લગી ગયો
એક પેશન્ટમાં જે
મોટા ભાગના 50 પીડી માં સમજાય
અને that patient is also underwent CRT and now it is on reducing.
અચ્છા
અને આ પેશન્ટ તો છે ને સરપ્રાઇઝિંગલી હાઇપોટેન્શન બહુ સારી રીતે ટોલરેટ કરતા 90
even with 80 BP they are stable and we can continue with that.
આરામથી ટોલરેટ કરે yes
This is also same 4 pillar. The 5th pillar is loop diuretic, which we need to use in initial phase of acute decompensated heart failure or it is class 1 symptoms. But still, even after saying this, 2019 CHEMP registry did told us that ARNI use is very less. This is the patient. Red color is a stable sub-target or no medicine patients. The number is very high for ARNI. This is also not worldwide data. This is also only multiple centers. Beta blocker also has been
must
used
be in a
very less.
developed country only
Developed country.
તો એ આટલું ખરાબ છે
India માં ખાલી એક કે બે જ છે સેન્ટર.
અચ્છા ઇન્ડિયાના છે સેન્ટર
હા એક કે બે જ સેન્ટર છે. That is also Delhi, Bombay. But still, all developed country also.
વડોદરામાં
We are talking
સારું
about
હશે.
guidelines.
વડોદરામાં આના કરતા સારું છે વડોદરાના ફિઝિશિયન બહુ હવે છે
The ARNI use has been increased. This is 2019 when ARNI was still under only one company.
વડોદરામાં 300 ફિઝિશિયન છે
300 તો લગતા રહેશે 300 તો લગતા રહેશે
Price reduction પછી this data must have changed.
પ્રાઇસ રિડક્શન પછી ડેટા કોણ જોવે છે પ્રાઇસ રિડક્શન પછી કોઈને કઈ પડી જ નથી આ બધું બ્રાન્ડેડ દવા વેચવાની જ નથી સરખી
To conclude, early acute phase during admission, we should start thinking of therapy so that this red color, that is a clinical decompensation, comes down fast. And during this blue phase, that is a discharge condition or ongoing optimization, we have to add all 4 drugs before discharge so that we get increased amount of guideline directed medical therapy and this ongoing optimization takes place. So with first follow-up, we should start up-titrating the doses of all 4 pillars. એના પછી કંઈ નહીં, ડેટા છે.
પણ ત્રણ ચાર
આ બધા નવા trial છે.
ને ડિસ્ચાર્જ કરવાનું હોય તો ચાર ચાલુ નથી કરી શકતા.
નથી કરી.
That is, આ બધું કહે છે પણ
We start on at least MRI, ARNI, beta, SGLT2 પછી follow up માં જ રાખવું પડે. And only one subset where data is not yet robust or not even a head to head. That is paradise MI, that is patient who are having acute myocardial infarction with heart failure, where till now sacubitril valsartan has not shown any beneficial effect. So एक જ subset છે heart failure with acute MI, which is not yet beneficial. બાકી all heart failure
એમાં તો પામી જ કરવું.
પામી છે, પછી બાકીના ત્રણ પિલર છે that. But unfortunately we have only one trial for that, paradise MI. As ACE inhibitors are beneficial in acute MI with heart failure, ARDS alone are beneficial. Some new trial will also show that it is ARNI is also beneficial.